Muhammad. Dear President of Jabir University, Medical University, and dear my teacher, dear my teacher and dear attendants, welcome to this is a scientific lecture, and I thank you for giving me opportunity to present my case. It's a case report that published in Science Publishing Group, Journal of Surgery in America last March about separated axillary tuberculous lymphadenitis. We go for extrapulmonary TB to count about 30% of all TB cases, and lymphadenitis account about 17 to 43% of the cases. Of course, cervical lymph nodes constitute the most common site involvement, with axillary nodes both at about 3.8%. For isolated axillary tuberculous lymphadenitis, it is a rare description that the patient have just axillary TB lymphadenitis without previous active pulmonary TB, or there is no evidence of origin of TB detected in the body anywhere else. Tuberculous lymphadenitis presented as a painless swelling, progressive swelling of single or multiple group nodes at about 85% in the cases unilateral. Tuberculous lymphadenitis is the local manifestation of systemic disease. For axillary tuberculous lymphadenitis, it is rare and is a major prevalence between 20 and 50 years old. Our patient is about 45 years old female that presented to the outpatient clinic, have a left axillary swelling. It's about 6 months duration. The swelling gradually increased in size and was painless. There is no history of constitutional symptom like low-grade fever, night sweat, no cough, no anorexia, and there is no change in the breast and in the left upper limb. One examination that reveals the female with a good health. There is a swelling in the left axilla, about 3 cm diameter, and the mild tenderness and the firm, smooth, rubbery consistency, the mobile. Examination of contralateral of the axilla, the normal, and examination of whole breast, the normal. Examination of the left arm, normal. Also, examination of lymphadenopathy, like in inguinal, cervical, all are non-remarkable or no significant increase in size. Investigation, patient like complete blood picture and chest X-ray, ultrasound, all these are normal. But ultrasound, there is done for both. The Doppler study also show that there is enlargement, matted axillary lymphadenopathy with suspicious of secondary metastasis or lymphoma. So viral screen done and patient proceed for open biopsy. When biopsy taking microscopically, this would be found by histopathology. There is loss or destruction of lymphoid architecture and with multiple granuloma. The typical caseating granuloma with the presence of multinucleated giant cell. Also, I acknowledgement for Dr. Aswar, a pathologist, that provide me this slide about my patient. So the diagnosis of TB. TB lymphadenitis is the most common clinical presentation of extrapulmonary TB. Tuberculous lymphadenitis can be local manifestation of systemic disease. For extrapulmonary TB, incidence has been reported increase in recent years, including subset of lymphadenopathy, in keeping with this rare report of an separated axillary lymphadenopathy. For axillary tuberculous lymphadenopathy, it's a rare. It's presented as a differential diagnosis with a breast carcinoma and has a major prevalence between 20 and 50 years old, which was keeping with our patient age of 45 years. The major diagnostic challenge in this case that is having no clinical evaluation, have no history of constitutional symptom, no breast lesion, there is no left limb lesion, no underlying skin lesion. So the initial thought that was may be possible of lymphoma or it's occult breast carcinoma. Axillary tuberculosis lymphadenopathy remains a rare condition and should be considered in a patient living in endemic area of TB. In situation of diagnostic dilemma is a confirmation diagnosis by histology with keeping with our experience. This is diagram show that is a mainly extrapulmonary TB, and the main extrapulmonary TB, it is lymph node and is the less percentage about 11 axillary TB. Conclusion: tuberculosis, systemic disease, and lymphadenitis is the most common extrapulmonary manifestation of the disease. Their diagnosis and distinction need a high index of suspicions and application of suitable diagnostic modalities. Microbacterial infection should be considered in the differential diagnosis of axillary swelling, especially in the endemic area. It must be considered about some particular infection like TB when we do ultrasound examination of the swelling of the lymph node in the axilla, especially if there is no significant breast lump. Thank you for attention.
شكرا جزيلا للدكتور سامر الحكاك. الآن يتفضل الدكتور علاء عبد الكريم لتقديم مشاركته بعنوان TB anterior chest wall.
To start with, just two very short cases of interest. حقيقة ما لحقت بس حبيت أراوكم إياها. أجاني أحد الزملاء طبيب فوالده 65 years age, and he had generalized lymphadenopathy. Generalized lymphadenopathy with parasplenomegaly and ascites. Diagnosed as a case of possibly advanced carcinoma or lymphoma or something like this. الحقيقة كونه طبيب يعني كل اللي أريده منك تأخذ لي أكزيلري ليمف نود وهاي هو مو فيزيشن يعني. I want to know the history. It said no need just to take a biopsy from inguinal region as a lymph node, sizable. Inguinal, axillary. I don't know whether cervical here. Actually, I don't. It's not to take. Better to take from the axilla rather than inguinal, because inguinal have non-specific infection and larvae. Actually, I took the axillary lymph node and just bisected in the theater, and I could got multiple causation. Generalized lymphadenopathy, hepatosplenomegaly with ascites. This is another. This is the first case. Second case, this is an Indian. هذا بالخليج. This is an Indian presented with swelling in the chest wall. He was around 35 years age like this, and he was completely normal, and he was walking nicely and everything. even no fever. He said sometimes the sweating, you know, the Gulf area, always there is sweating because of the weather. Anyhow, this mass. This is the mass I did for him, chest X-ray. The radiologist at that time, he didn't give me exact result. So the CT scan showing this mass. This is another one. I mean the same, another CT. This is axial view, and actually when I did open that patient, it was showing caseation and tuberculosis. Just like this patient I saw here in Iraq, the same thing, chest wall swelling and liver abscess. The liver abscess conveyed already at a sharing cover of antibiotic, something like this. And she came to me with chest wall and it proved to be, again, tuberculosis. And the liver one started to recur because they dealt with as a case of just an abscess rather than tuberculosis. But I have no slides about. But the most important thing that I would like to present actually this case. طبعا let's say no details of why عليه لأنه الحقيقة it was a gloomy history. This is a 20 months child age. He was from Basra. This is not exactly his picture, but it's not his picture. But exactly the same thing, the same. He brought us a swelling. He was okay, stable, no loss of weight, no fever, no history. تسألهم الأهل sweat or they didn't give you good history from Basra. What happened? They said, well, just we have this swelling. They did for him, already done for him, جابوا لي تحاليل وكذا, CBC. The only positive finding is the hemoglobin 9. And chest X-ray, chest wall ultrasound already done in Basra. There is heterogeneous lobulated outline solid soft tissue mass, 3 by 2 centimeter, possibly aneurysmal bone cyst. I will show you some other picture of interest. Again, they did for him CT scan. CT scan, this is bone eroded. Again, bone eroded. And this is bone window for the chest wall affection. Affection, not infection. Affection. And the result was, you see, 6th rib on the left side. The CT scan result, I mean the report, they said that suspicion of skin tumor. Actually, I went to see what's this skin tumor. They said this is a neuroectodermal tumor of embryonic origin or anyhow, I checked this skin tumor is a primitive neuroectodermal tumor of thoraco-pulmonary region described in 1979. Anyway, بعدين it's اعتبروها من types of Ewing sarcoma and peripheral primitive neuroectodermal. That is the skin tumor, according to this picture. I started to do for him ultrasound. Actually, from the ultrasound, they said expansile lesion, possibly it is, and this is very important, dumbbell appearance. Picture suggesting bony tumor, chondroblastoma. I did take a biopsy, fine needle aspiration biopsy. They could find germ cell and some chondroid matrix and some other, and possible differential diagnosis according to the fine needle aspiration biopsy was aneurysmal bone cyst or germ cell tumor. I took the patient to the theater. When I started to operate upon, I opened the area, then I got just ordinary pus. Then I went deeper. I get the pus, and then I have a track, and then again pus. Back on the bone, I could find causation. Then I resect the affected bone, the rib, and the closing without any drain. We have not to put a drain. I asked the anesthetist to increase, to ventilate, and then I closed without a drainage. I sent it, I received, the result was a tuberculous osteomyelitis. Actually, from the start, when I saw the causation, I start empirical anti-TB measures. Because we have to wait for 10 days for removal of stitches, or 7, 8 days. If it is tuberculosis, does it heal? Anyhow, that is my case, proved to be by and the original picture that when they said germ cell tumor, actually they could see the Langhans, possibly germ cells. And this is the child. الحقيقة أنا ما صورته أول مرة لأنه كنت أتصور أنه في simple things وبعدين قالوا bone tumor, it is not related to my specialty. But actually this is the child, 20 months. فقلت خليني أروح أبحث other cases, أكو كيسات. فلقيت بماليزيا في article مارش 22 جانوري 2016. شوفوا الكوانسيدنس او مو كوانسيدنس، صدفه انه child aged only 20 months having TB causing rib destruction, primary tuberculosis osteomyelitis of the rib is a rare. طبعا أنا ما ناشرها بعدها، بس شفت هذا الارتيكلز. الصدفة إنه هذا هم 20 أسبوع وهم TB osteomyelitis of the rib. Anyhow, thank you very much.
Thank you so much, Dr. Ala Abdel Karim, for your nice and informative presentation with really interesting cases. So thank you so much. الآن أدعو الأستاذ المساعد الدكتور عادل صاحب الميالي رئيس فرع الجراحة العامة لإلقائه المشاركة. شكرا جزيلا.
السلام عليكم ورحمة الله. سيدي الجماعة مساء الخير. إذا أشهد سعادة الأمر شرفتونا بحضور هذه الندوة، وموضوع الحقيقة جاء إلى ذهني واختاريت أن يكون عنوان لهذه الندوة هي مجموعة الجلسات الجراحة. كنت اتصور انه التي بي is not a common disease in this territory. لما جيت سنه 2000 خبير اختصاص في هذا المحافظه في خلال 3 سنوات انا انصدمت ان هناك 16 كيس تي بي اتاك اللي انتهت كليتها في خلال 4 سنوات من سنه. وهذا كان اول اشاره انه should expect this. يعني المشكله الثانيه طبعا بسم الله الرحمن الرحيم اللهم صل على محمد وآل محمد انه الاكسترا pulmonary TB is increased. The rate of extra pulmonary TB is more than the pulmonary itself. Head and neck region constitutes around 10% of all cases of extra pulmonary TB. So 10% is not a small number when we took it. The cause for this rapid increment in the extrapulmonary TB nowadays and the new emergence of new cases of TB is probably the spread of HIV infection. This is the frequency of head and neck lesions diagnosed with TB. Cervical lymph node is the common site. The larynx is the next temporal bone, that is the ear, 6%, sinonasal cavity 3%, the pharynx, mainly the tonsil 2%, thyroid gland, and skull base 2%. Why TB? Why TB هو هذا الريبورت اللي راح نسولف عليه اللي طلعته ال WHO سنة 2006. There were 9.2 million new cases of TB, 1.7 million deaths from TB, of which 0.7 million cases and 0.2 million deaths were in the HIV positive patients. Asia and Africa, they account for 85% of the global cases of tuberculosis. Then it deserves the disease to be studied again. هاي العبارة أذكر بالخير أستاذي الدكتور عادل منصوري كنا نسمعها دائما وياه أنه كل vague presentation in head and neck بويا لا تنسون التي بي. الكلمة اللي